Hi everybody, it's Laura again, just looking at liver function tests, a really quick, easy overview refresher, not an absolute deep dive, and I will not be looking at hepatitis in this presentation. It will be covered separately, okay? So just an introduction, we'll look at liver anatomy, the role of the liver function tests, some case studies, and a bit of take-home and hints for going forward. So the liver anatomy, the liver is located in the right upper quadrant of the abdomen. It sits just below the diaphragm. It extends from the left to the right underneath the ribs. It's shaped like a wedge. It's got 4 lobes and 8 segments, and you can see them on the diagram. It's the largest visceral organ in the body, and it's the largest gland in the body. So visceral really just means that it's the largest soft internal organ, so like the heart, the lungs are organs, but the liver is the largest within the body. It receives 25% of its blood supply from the hepatic artery, which is down underneath across from segment 5. It gets 75% from the portal vein, which is right beside that. It gets the deoxygenated blood from the GI tract and the spleen, and then it gets its nerve supply from the parenchyma, which is the hepatic plexus. So that's the fibers that cover the liver, and they can give the sensation and the feeling and the pain. So there is a Gleason's capsule which covers, and that's supplied by the lower intercostal nerves, and that's the one that actually we call capsular pain when the patient has pain if they have disease within their liver. Just another picture again, just to show you what the liver is like, with some of the arteries and the gallbladder there and the common bile duct, so you kind of can picture it in your head, so you know what we're talking about when we say someone has a gallbladder cancer, or they've had stones in their bile duct, or on the previous picture, which segment, I'll just quickly go back if I can, to see which segment the cancer's in within their liver as well. So the liver is covered by a fibrous capsule called the tunica fibrosa. It also has a visceral peritoneum, so that's a serous membrane that covers most of the liver to reduce friction, and that's called the tunica serosa. There is an area without that at the back, where the liver actually touches the diaphragm, and it doesn't actually have a covering. There's ligaments within the liver as well. They're called falciform ligament, and that connects the liver to the anterior abdominal wall and the diaphragm. And then we also have the coronary ligament, which attaches liver to the diaphragm again, and we've also got other ligaments that attach it to the omentum, so the lining in the tummy and parts of the stomach and the duodenum, and they're in place to protect the liver, reduce friction, and hold it in place within the abdominal cavity. So basically, what does the liver do? So functions. It detoxifies, so it cleans blood by breaking down the toxins in blood from drugs, alcohol, chemicals. It processes the bilirubin that passes through, so it breaks down hemoglobin and red blood cells and makes hemoglobin, whether that be conjugated or unconjugated, and we'll talk about that. It metabolizes, so it makes glucose from non-carbohydrate sources called glucogenesis, and it stores fat and exports fat for energy. It synthesizes proteins, and these proteins are used to help with transport, immunity, and blood clotting. It also helps to form albumin, which helps maintain blood volume and bind substances. Sorry about the emails coming through. It also makes clotting factors like prothrombin. It makes bile, so that's made by the liver and stored in the gallbladder to help digest fat. It helps with hormone regulation, sex hormones, thyroid hormones, cortisol and growth factors, and it also makes cholesterol, and it converts that into essential substances for absorption, and it actually stores vitamins such as A, D, K and B12 and other minerals such as copper and iron. So it's got a really important job. So what are actually liver function tests? So there is a full liver function screening. I've got a picture of that at the end, but we're talking about looking at the most commonly ordered blood tests such as alanine transaminase, ALT, aspartate aminotransferase, AST, alkaline phosphatase, ALP, gamma, just saying gamma, GGT, bilirubin, and albumin. But why do we look at them is another good question. So we assess LFTs to look at liver health basically. They can sometimes be done as part of routine screening for infections, whether that be hepatitis, a bacterial infection, or like a parasite, a little bit rarer. We do them here in medical oncology as part of our diagnostic process. They're normally done as a screening, but they're also done in pre-treatment. So if we've got a patient who's starting treatment, we'll want to check their liver function test, obviously, because a lot of our drugs are metabolized by the liver, but also if we have a patient in clinic as a new patient and they have a history of alcohol, we want to check the function of the liver. We want to check them for hepatitis and cirrhosis. We can also check for any illicit drugs. And we want to know if there's any family history or genetics such as hemochromatosis. We also look at a non-alcoholic fatty liver disease in obese patients, and we want to check its function if we think the patient actually looks jaundiced, so that yellow discoloration of the skin. So it's really important. Blood tests for liver function tests are done to monitor pre-existing disease, as I said, such as a viral hepatitis or an alcoholic hepatitis, cirrhosis, and patients who have liver cancer. And this helps to see if any treatments that they're on are actually working. And we actually use the blood test to monitor for side effects. So an example would be immunotherapy hepatitis, or if the patient's on irinotecan or gemcitabine, are they having paclitaxel? Are their liver function tests changing? And other patients that are on medications such as valproate, methotrexate, someone who's had a paracetamol overdose, and other targeted therapies as well. So there's a lot of reasons why someone would have their LFTs checked. So what are they? So alanine transaminase, ALT, also known as SGPT. You can see that written in other places. Very first off, before we go any further, just to remind everyone, the reference range here is our reference range at the Mater. It's our pathology's reference range. That may change if you use an external provider or Path North. So we could look at our reference range being 10 to 35. Some places go up to 50, depending that, if you use Laverty, Douglas Hanley Moyer, Foresight, or as I said, Path North. So you've got to be very careful that you actually know the range as well. So you know that when there is a dysfunction, you're grading it appropriately. So ALT is a liver-specific enzyme. It comes from the hepatocytes, so the hepatic liver cells. It converts proteins into energy for liver cells for maintaining their function. And if the liver is damaged, ALT is released into the circulation. Aspartate aminotransferase, or AST, again also known as SGOT, reference range again the same. Now that is a liver-specific enzyme also from the hepatocytes. It breaks down amino acids, and if the liver is damaged or there's disease or muscle damage, AST can be released into the circulation. So that damage can be from hepatocellular injury, liver injury, cirrhosis, hepatitis, drug or toxin induced, and also malignancy. And we'll talk a little bit about ratios. So if the AST-ALT ratio is 2 AST to 1 ALT, so if the AST is 20, and the ALT is 20, if the AST is 40 and the ALT is 20, they're obviously very low. They're within normal ranges, but if you had something like that 2 to 1, you can have a suggestion of alcoholic liver disease. So you'd be looking at like an AST of 200, which obviously is high, but an ALT of 100, so 2 to 1. So you've got to be looking at the numbers and actually figuring out what is normal, what is abnormal, and when it's abnormal, how abnormal is it, the range of abnormality. If it's really markedly elevated, we need to be thinking that there is an acute hepatitis or a drug-induced ischemia or injury. There could also be muscle injury or a severe illness. And if any of the levels are into the hundreds, then that's an urgent thing. But we've got guidelines here as well that I've got a picture of that I'll show you later. ALP and GGT, so alkaline phosphatase, ALP, reference range 30 to 110, non-liver specific enzyme from biliary epithelial cells, can be found in the small intestine, kidney and bone. So liver damage or bone damage, ALP can be released into the circulation. And GGT, glutamyl transferase, is 5 to 35 reference range, derived again from hepatocytes and biliary epithelial cells, and can be elevated in alcoholism, obesity, pancreatitis, anticonvulsant meds, and some hormones. Then GGT is released into the circulation. ALP and GGT are looked at together normally to identify the source of the raised ALP. So if the ALP and GGT are both elevated, you'd be thinking that it's like a liver cholestasis, biliary obstruction. But if the ALP is raised and the GGT is normal, you'd be thinking it's more of a bone origin problem. GGT is really sensitive to alcohol and barbiturates and phenytoin and oral contraceptives. And an isolated rise is not diagnostic. It's more that we take it in conjunction when we review it with the ALP. So as we said, like if the ALP is high, the GGT is high, we think it's a liver issue. If the ALP is high and the GGT is normal, it would be bone. But if the ALP is normal and the GGT is high, then we might need to look at some drugs to see what's going on. Or again, is it the patient's a little bit overweight? So bilirubin, reference range less than 20. It is a byproduct or waste product of red blood cell breakdown and hemoglobin breakdown that passes through the liver and is excreted in the feces, not faeces, obviously. Spell check didn't work, my apologies. So we'll sometimes talk about unconjugated and conjugated bilirubin. So when we look at unconjugated, now that is that waste product which is not water soluble. So it actually has to attach to albumin to travel through the bloodstream to the liver for processing. And there at the liver cells, the hepatocytes, use it and metabolize it to form conjugated bilirubin, which is water soluble. And that's where it can actually be passed to the bowel as bile, but it also then can be metabolized by gut bacteria in bile to form urobilinogen, and that's what gives feces its dark colour, and some of that is actually reabsorbed and excreted as urine. So that's two different forms of conjugated and unconjugated. Unconjugated high bilirubin is normally Gilbert syndrome or hemolysis that over increased breakdown of red blood cells. And an elevated conjugated is normally coming from a liver problem, and it can end up causing jaundice as well. LDH and albumin. LDH, lactate dehydrogenase, reference ranges there, is an enzyme, but it's actually found in nearly all cells because it's used to convert lactic acid to pyruvic acid during glycolysis. Sorry, phone's gone. Or the reverse. So during glycolysis, the enzymes, the glucose is broken down to release energy and also the pyruvic acid. So it's not actually helpful as a liver marker for injury or dysfunction, but it can also be affected by other transaminases if they're elevated, can be elevated in cancer, obviously, and tissue hypoxia, necrosis, or if cells are rapidly turning over. And that's why it can actually be used as a marker in a lot of cancers. So we know that we use LDH when we're looking at patients with germ cell carcinomas and also our melanomas. So it's quite important when we're reviewing patients as well to keep an eye on the LDH. That's why you'll see it on a lot of pathology forms as well. Albumin, the reference range is 31 to 47. Some places are 35 to 50. It's a protein made in the liver to maintain fluid balance, transport hormones, vitamins and minerals. Its long half-life is 25 hours, so it can actually take a long time to decrease, even if the liver has got severe disease. It helps fluid balance by preventing fluid leak from the blood vessels. If it's low, it can indicate that the liver isn't functioning well, as in disease. It can also point to malnutrition, chronic inflammation, and also kidney disease. If it's high, it can indicate the person's under stress, either from illness or they can be dehydrated. It can be high in burns or myocardial infarction. It actually reflects the liver's synthetic function of protein making. If it's low, it can actually signal chronic liver disease, but it can actually, as I said, be from malnutrition or other protein losses within the body. So if your albumin's low and you've got abnormal liver function tests, it can point to chronic liver disease. But if it's low on its own and the rest of the liver function tests are actually relatively normal, then we'd be looking at other causes such as kidney disease, inflammation, or malnutrition. So it's important. And it also comes to, when you look at albumin, to look at the other proteins, the globulins and such. But that we take into consideration depending on the patient presentation. So there is a huge variety of reasons that LFTs can be abnormal, and normally we're looking at medications. Is it something we're giving them? Is it something they're taking over the counter? Is it something another practitioner has prescribed for them, whether that be a GP, cardiologist? Not very often, but you never know when you look at medications. A naturopath, a herbalist, or it could be something that their family member has thought has really good evidence online and they bought it online and it's come and they've started taking it. So we've got to be very, very careful that we check about medications. So we also look at alcoholism as well. And then we look for other causes, which can be the list on the right. One of them can actually be the Wilson disease. In the picture there of the Kaiser-Fleischer ring, it's a rare inherited genetic disorder where the body builds up copper. So that can be seen as well. And there is another ring around the eyes, which is from high cholesterol, so not to be mistaken. So they can get a arcus, a corneal arcus, or arcus senilis, which is a fatty deposit around the cornea, and it's normally when the patient's actually got a high cholesterol, but that colour's normally white or grey, whereas this one's a little bit more browny. So we look at, obviously, LFTs in diagnosis, and on management and going forward, and we try to look at ratios to see where we think the causative factor might be. So, and we always ask the patients, have you started anything new? You know, where are you up to with this medication, that medication, what's going on? So we try to keep up to date with all of the patients' history and changes, which can be quite hard, but we do really well at it, I think. Also Gilbert syndrome. Now that is a hereditary condition, so it disrupts bilirubin metabolism. It's an autosomal recessive syndrome which causes mild to moderate unconjugated hyperbilirubinemia. So that means it's actually the individual person inherits 2 copies of a mutated gene from each parent. It can be 2 to 10% in some literature, but roughly around about 5% of the population. It actually comes from a deficiency of glucosyltransferase. Now that's an enzyme responsible for the conjugation of bilirubin in the hepatocytes, the hepatic cells, and it can be seen as transient elevations in bilirubin. A lot of people develop it following viral infections. It can be really benign, doesn't normally require any management, but it's just that to be mindful of when you're looking at LFTs that bilirubin can fluctuate. So we normally then look at their family history, alcohol intake, and their drug history. And we just know that because of that deficiency, they can get a slightly higher risk of developing drug toxicity. But they're normally absolutely asymptomatic, but we know that things can affect it. So we just try to be mindful of that when we're looking at pathology. Just a really quick slide on diagnostic patterns, which might help you. So again, like we said, if we're looking at ALT that's higher than AST, we can be suggesting hepatocellular injury. ALT can be up, but ALP might be normal, so it could be a cholestasis picture, or it could be a mixed picture. So we look at all of them together, but this is really just a little bit of a go-to, really. And this is just basically, if someone's got an LFT dysfunction, then we might want to look at doing a hepatic screen, so a liver screen. So we look at coagulation, hepatitis, Epstein-Barr virus, cytomegalovirus. So this is a lot of the other ones that will be done to try and help point us in the direction of the underlying cause of the LFT dysfunction if we don't actually already know. 9 times out of 10 we do. We know it's one of our drugs that we give, or it's something that they've commenced on, or they've been smoking marijuana, or whatever it may be. So, but if not, then this is where we would go next to look at trying to cause. So really just a quick case study on a chemo. So I had a 61-year-old man who's got metastatic colorectal cancer, who is having FOLFIRI bevacizumab. He comes to clinic pre-cycle 2 for review, and his pathology shows that his ALT is 346 and his AST is 105 with a normal bilirubin. So if we look at that, then his ALT is 9 times the upper limit of normal. His AST is 3 times the upper limit of normal. So he was well within himself, didn't understand why there was a problem. He had a history of drug and alcohol use, and he also had hepatitis previously. So we delayed treatment. We actually gave it just under a week later with a dose reduction of the irinotecan to 75%, and all of the drugs stayed the same. He was actually on steroids from palliative care, and he denied nothing else new. He denied alcohol, illicit substances, nothing. So I had to take him at his word, which we have to do in clinic. So then we asked them to repeat his bloods again. And his ALT had come down, his ASD came down, and his bilirubin remained normal. We didn't do an interim again, we just asked him to do it before cycle 3, and it showed that the ALT and the AST were both coming back down and returning to baseline, so just indicating to us that irinotecan, again, as we know, can cause LFT dysfunction, and that dose reduction has obviously helped. So irinotecan is metabolized in the liver to its active metabolite, and the hepatotoxicity or the LFT dysfunction is actually linked to dysfunction of the mitochondria within the cell and oxidative stress. So macrophages are activated, upregulated, and inflammation happens. Lipid metabolites are impaired, and we get an LFT dysfunction. So that's why we should be checking before each treatment and checking in with the patient if possible. And it doesn't always have to be face-to-face if they're well. And just another quick review of patient 32 receiving adjuvant nivolumab for her resected melanoma. Came to clinic pre-cycle 4, and her path was ALT, AST, and bilirubin elevated. So she was completely well, asymptomatic, no issues at all. However, because she was on immunotherapy, obviously, we had done a review. So we did a hepatitis screen. We actually did an ultrasound of her liver. She was asked to do PATH every 3 days, and we did a coagulation profile just to check her liver function. So we had held treatment until we got the hepatitis screen and the first set of PATH back. Now, the ultrasound was negative. There was nothing to be found, no metastatic disease, no inflammation, no fatty liver, nothing. The hepatitis screen also was negative. She was put on the wait list for gastro because obviously they have a really long wait list. But she was fine. But when we called her at that first lot of bloods to check in with her and they were improving, she actually said, "Oh, I forgot to tell you, my GP gave me antibiotics for a skin rash." And we were like, "Right, okay then." So we organised to get treatment back. So just a little bit of take home. As we know, LFTs are essential in assessing liver health and injury patterns. We know that we assess it all the time and we look at it all the time, and it's just about educating the patient to phone us if they have any problems, but they may not. They may actually be asymptomatic until it's a little bit too late, or the LFTs are really high. So we know we monitor trends in bloods, and we always try to correct any changes, and we escalate when we're worried or concerned about it. So you guys we play a really key role in early detection, management, escalation. So if the ALT is higher than the ALP, we're kind of thinking it's liver. If we think the ALP and GGT are high, we're thinking it's obstructive. And that's where we go with that. We're worried about bilirubin, and we need to look at that because we know patients can get jaundice, and we want to know why, and we need to make sure they're not obstructed and need a stent. Isolated rises not always indicate liver disease. We need to look at the clinical context and patient and their history. And again, as I said, ask about new medications, including herbal supplements, vitamins over the counter, online, naturopath, family, friends, whatever. Ask about any other symptoms. Ask about the alcohol and drug use, including illicit drugs, including marijuana. A couple of little hints, as I said. So AST-ALT ratio can determine etiology of the liver injury, and we're looking at a 2-to-1 ratio for alcoholic liver disease if they're elevated. An isolated GGT can be associated with alcohol. Jaundice is not normally seen until bilirubin exceeds 50. As we know, the liver makes clotting factors, so if the function of the liver is affected, we do know that clotting factors are not being produced, so we need to watch for coagulopathies. Bilirubin is a marker of severity and acute obstructive pathology and injuries, and jaundice means that they've got severe disease, so there's something seriously going wrong with the liver. We can look at isolated bilirubin rise without a change in LFTs to think about prehepatic jaundice or Gilbert's. Synthetic functions of the liver become impaired, leading to decreased albumin if the liver is injured. When we have chronic pathology like cirrhosis, the bloods may return to normal, but the function still remains impaired. It just means that it's actually trying to repair itself. And so the liver actually will make glucose, which is gluconeogenesis, and it makes it from non-carbohydrate sources. And we need to assess that as well, because that can be impacted if the liver's function is impaired, and it can be the last function to be impaired in liver failure. When liver injury is really bad, that's a bad sign, obviously, and it's not got enough liver cells then for metabolizing bilirubin, and jaundice can develop. Just remember that we do have departmental guidelines for you to look at for treating patients, and we have them for dose modification of chemotherapeutics due to hepatic dysfunction, and that's been made for here only. It is on the shared drive, so you can go and look at that, and I've put the little pathway. So your PC shared drive day treatment centre nursing folder, and there's also some guidelines on release of drugs and when to treat patients with neutropenia and low platelets. So that's also in there. So there's 2 really good resources for helping guide treatment. I've just got some references. I've put in abnormal LFTs, but this is normally from the GP, so this would be primary care. We'll put in another little table of dysfunction and what does it mean with the separate bloods that we actually look at: ALP, AST, ALT, and GGT. All right, any suggestions, let me know. I've started a Teams channel and a Teams chat at the minute. There will be a channel coming in the future, and let me know any comments, suggestions, questions, anything. Please send me them. I'm happy to help if I can. Okay, bye. So just a little bit on grading. When you come to grade your transaminitis or your elevated ALT, AST, first off, you want to look at the level. So in our chemo example, we have an ALT of 346. So in our pathology, the upper limit of ALT is 50. So 346 divided by 50 equals 6.9. So his ALT is 6.9 times the upper limit of normal. And when it comes to his AST, that's 105 divided by 35. So that's 3 times the upper limit of normal with a normal bilirubin. Hence, that patient had a delay. And when you want to look at that, we would go to our hepatic guidelines, like we've mentioned. So they would be the hepatic ISBAR. So what we would be doing is actually looking at the drug they're having, which was oxaliplatin, and that is in the group, FOLFIRI, sorry, he had FOLFIRI, so irinotecan. So that's a group 1, so that's got high hepatic clearance. So when we try and grade it with the grading down the bottom, his bilirubin was normal, but his AST and ALT were deranged. So he's still going to be at any derangement. So it's going to be it's a minimal, but we still want to protect him and his liver function. So even with a minimal, we reduced the drug. So we did on him, we delayed and we did a dose reduction. And when we look at our immunotherapy patient, it's a little bit different because you have to go into EVQ and look at the grading of the management as per the guidelines. So if we went to adjuvant nivolumab and hit on for the management of immune-related adverse events, we'd know that the ALT is 115. So again, ALT is 115 divided by 50 is 2.3 times the upper limit of normal, and the AST is 146 divided by 35, which is 4 times the upper limit of normal, and her bilirubin was abnormal. So we wouldn't be looking at our chemotherapy guidelines, we'd be looking at our immunotherapy management guidelines. So for her, the hepatotoxicity is a grade 1. She was asymptomatic. Her AST or ALT was between 1 to 3 times the upper limit of normal. However, 1 was nearly 4. So that's why she was delayed as well. And her bilirubin was also abnormal. So she was delayed, awaiting repeat pathology when, if you remember, she said that she'd had antibiotics from her GP. The difficulty comes when we look at our chemo and IO combinations, which is becoming very more frequent. So recently I had a gentleman with cisgem-nivo who had ALT of 88, which is 1.7 times the upper limit of normal, and he had an AST of 68, which is 1. I'll just work that out because I can't calculate. 1.5, and his bilirubin was also elevated at 1.25. So when we use the chemo guidelines, he's a mild derangement because his bilirubin is 1.25 times the upper limit of normal with an abnormal AST and ALT. So when you go on to looking at the chemotherapy, in his instance, it says that we can continue because he's a mild, because we look at the guidelines, or hepatic guidelines again, and he's a mild derangement because bilirubin and AST, ALT are deranged. He was having gemcitabine, the drug that we would worry about, and that's a group 3 drug, which is mild derangement, no dose modification necessary. So we know we can continue from that perspective. But he also was on nivolumab. So we have to look at our immunotherapy guidelines, which we did. And with that, he's a grade 2 because of his derangement. Hold on, grade 1, I believe. Got myself confused now. He would have been a grade 1, sorry. So we knew we could continue treatments safely, which we did. So that's just about how you're grading them and looking at them and where to look and what to look at. And remember that the hepatic guidelines are for chemotherapy. If the patient's having immunotherapy, then we still have to check EVIQ. Thanks.